Well, good evening, everybody, and welcome. Thank you for joining us for this webinar session tonight. We will be looking at recent aged care reform and how this will affect the provision of allied health services for older adults. My name is Sandy Vincent from the PHN Education team. I'm joined tonight by Joe Coots, who is the Integrated Health Manager here at the PHN, which includes the portfolio for allied health. And our presenter tonight is Scott Lynch. Jodie Lively is unfortunately ill and won't be able to join us tonight, but she has kindly provided us with her slides, and we will make sure that those are available to you with the recording of tonight's session on the PHN Education Library. Before we begin, I would like to acknowledge the traditional custodians of the land that we live and work on and pay respect to their enduring culture and the contributions they make to the life of this vast region. Just a couple of things to let you know. During the presentation, your camera is automatically disabled and your microphones are muted. If you do have questions, please make use of the questions box and send those through to us, and we will direct those through to Scott at the end of the session. An evaluation will come to you automatically at the end of the session. Please do complete that as your feedback's very valuable to us. It's now my very great pleasure to introduce you to Scott Lynch, who is the founder and managing director at Community Therapy, a growing allied health company in New South Wales focused on supporting older adults and people living with disabilities. Scott also serves as the vice chairman of the Australian Physiotherapy Association Gerontology Committee. Thank you, Scott. I'll hand over to you.
Thank you so much. Let me see if I can get the presentation working with GoToWebinar.
Perfect.
That looks good. Wonderful.
Thank you.
Thank you so much for the introduction. As discussed, we'll be covering aged care reform in residential aged care. Jodie was going to be speaking briefly across that aged care reform across the community aged care sector as well. So it's important to note that those slides and associated resources will be available to you as well, because there is plenty of reform going across all of aged care and across community aged care that's across programs such as Commonwealth Home Support, short-term restorative care and home care packages. So we're speaking to residential aged care in my presentation here, and it's been quite a, I guess, topical item across allied health in particular, but also residential aged care, facility managers, ACFI managers, and the like. I know that in attendance, either live tonight or following this recorded presentation, our audience is made up of a variety of different people in different positions, allied health, obviously, but also across residential aged care facility managers, ACFI managers like I've just spoken to, and hopefully seeing across GPs and practice nurses, and I'm sure others may be in attendance as well. So if you're not across what Anac is, it's the Australian National Aged Care Classification System, and we're going to be diving into that in a moment. So I've had an introduction of myself, but it's always nice to know, well, why am I speaking to this and what do I know about residential aged care? So I graduated from Newcastle Uni the best part of 12 years ago now, which seems like quite a long time ago. I've spent most of my career so far working within residential aged care facilities, predominantly across the Central Coast and Hunter New England region, but sometimes venturing into other areas and other states depending on where I was working. I founded Community Therapy about 5 years ago, and we've since been privileged to grow to a team of approaching 100 team members across a multidisciplinary team. We support predominantly across aged care, including residential aged care and community, as well as different community funding initiatives such as the NDIS, but as well as some other things like rehab at home for post-surgical care. So I'll just continue on. Some of the things that we'll be speaking to tonight, so I want to make sure that I leave plenty of time for questions. So make sure that you're popping questions as you go through this presentation with me in the chat. And if I'm not covering something that you had on your mind, please pop that in regardless, because this is quite a large topic, Anac. as well as there's quite a lot of other pieces of residential aged care reform that either have happened or are happening in the years to come under the reform landscape, and most of that in response to the Royal Commission. So please don't be shy with your questions in the chat, and there's no silly questions with residential aged care reform and in particular Anac. So we're going to cover just a little bit about the history, the structure, some of the tools and sections of Anac, what the classification sort of model looks like, some of the business rules, noting that I can only cover so much in this bit of the reform timing. I'm trying to give an overview of a lot of different things associated with Anac, and then some action items for residential aged care facilities, but also for allied health to consider regarding allied health. So keep in mind that I'm trying to keep this presentation predominantly focused on allied health, but it's important to know that Anac and the reform in aged care is wide sweeping and will impact many different areas of residential aged care operations. So a bit of the history, many people would know of the ACFI, the aged care funding instrument. It replaced a previous system, the resident classification system, known as RCS, before my time as a physiotherapist, but I definitely heard a lot about it and saw that within residential aged care facilities in their old notes. So that transition happened in 2008. We've had ACFI since then. It's been known for quite some time that it was no longer fit for purpose, and one could argue whether it was ever fully fit for purpose. But each funding model, I think we can all admit, has double-edged swords. There were some good components of ACFI, but there was certainly, in regards to allied health, some poor components. It was very focused on the care need of pain management, in particular for physiotherapy and occupational therapy-led pain management programs, but quite restrictive in opening up the access to the evidence base for allied health to implement wide-ranging rehabilitation, reablement, restorative care, wellness programs, through to opening up access to other allied health more equitably, such as dietetics, speech pathology, and many other areas as well. So the department, so the Australian government commissioned for the RUCs to occur, and so RUC standing for the Resource Utilization and Classification Study. So the University of Wollongong started that and completed that starting in 2017 and completing at the end of December 2018. And the purpose of that was to design a new funding model or a selection for the department to choose. And Anac was the resultant funding model that was proposed as the best fit for purpose tool to move forward with. So you can see that these things certainly take quite a lot of time, 2017 through to finally the implementation in 2022 certainly does take some time, and I know many of us have been waiting quite a long time for this transition to occur. It is worth knowing that at this time with COVID, Anac was delayed in its rollout as well. We were thinking that it was going to come in sooner, but obviously COVID has impacted many things across all sectors, and residential aged care being very impacted in its timeline. So the next piece of the puzzle was to trial Anac across residential aged care facilities to determine how the assessments would be administered, what the different outcome measures would be used, and trying to determine what the full suite of the tools being used would be. A lot of that took place, so we finished finalisation of the RUCs in 2018, moved into the trial in 2019, and then that being COVID impacted, but was completed in 2020. We've then continued on that pathway of continuing to refine Anac and price that out, as well as then a big piece of that was getting actual legislation through our federal government. And we saw that go through House of Representatives and Senate through this year, which keeps us on the timeline of Anac finally replacing ACFI from the 1st of October. So not too far away. We've, at the time of recording here today, we're at the 20th of September, and I'm sure many of you on the call tonight and watching after are in the midst of facilitating transitions of ACFI led pain management programs through to more reablement and restorative care programs through allied health. So through this year, a shadow assessment process for Anac has continued with the aim of having all residents classified under their Anac classification, so that that transition period from October will occur as smoothly as possible. On to a little bit about the Anac structure and what some of the main changes you can expect to see. So a nice way to think about this is we're having a change to the funding, and that's going to be administered or made up of several different things, one being a variable Anac component. And Anac is a classification of what the care needs or cost of care is for that resident. Part of the resource utilization and classification study by the University of Wollongong was determining what's that fixed component of care for a facility as well, and how does that vary metropolitan through to regional and rural facilities. And you'll see, or have seen already, but we'll see in the future, more speaking to the modified Monash sort of classifications of regions, and that plays into how the funding is administered. There was also a recognition of by the study that there was a cost associated with facilitating new residents to a facility. So there will be a one-off component of the funding for new residents. Now, if you've been working with ACFI quite a lot within residential aged care, you would have been used to things like low, medium, high, 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 how the classification of funding was for ACFI. Moving forward, the sort of language used may be more around case mixes and what is that classification level 1 through to 13 for that variable funding component. And arguably, one of the largest changes here is that this funding will be assessed externally. So ACFI has been assessed internally by the residential aged care facility and then subject to external validation by the Department of Health. Moving forward, and so far, Anac has been assessed externally by the external assessment workforce, and we'll speak to that soon. But that is a significant change in how the funding is assessed. An important thing that you'll start to hear a lot about if you're working within residential aged care is the National Weighted Activity Unit, or some people will start to shorten that as the NWAU, and that helps determine what's that funding allocated to each classification as part of the case mix. And it's important that that can be changed over time. So in terms of with costs increasing over years in the future and can be assessed by a body for the Department of Health, and that's covered a little bit later in the slides. So the base care tariff, that part of the Anac, recognises that approximately 50% of the care costs are not driven by care needs and provides a financial stability regardless of the changes in the care needs. And it covers fixed costs, clinical training, management, shared care activities, and many other things. So we have that component that we know is quite fixed irrespective of the case mix. And then we have that actual classification component of residential. So you probably find at this part of the presentation, a lot of this may be quite a lot of information, and I'm trying to sort of just orientate you as best as I can that there's quite a lot of pieces to Anac here. Some people may be quite across this already, others I'm just trying to get across some of the main points that you'll start to come across. The NWAU, that base care tariff, and as I mentioned previously, the modified Monash, which is the MMM there, recognises that that weighting varies depending on where that facility is located, but also the case mix of that facility and notes that the cost of care varies dramatically from metropolitan all the way through to rural and very remote. Looking at the care component of Anac, there's a classification tree that comes into 13 different categories. This table shows on the right side of the column how the NWOW changes depending on the care needs, and it's easy to speak to this component. I'm just going to jump across here and then circle back. It's easy to look at this column actually into the case mix, because what this shows you is that one of the predominant ways that care is the cost of care changes depends on the mobility of a resident. And most of us working within residential care for a long time know that to be true, that a resident, an older adult that we're looking after that is no longer mobile, requires a lot more support and a lot more care hours to look after, and a lot more other associated costs as well. And we also know, if you look into the middle component of the classification tree, that compounding factors, including cognition, drastically change the cost of care as well. An important part to note at this stage with Anac is that it is externally assessed, and the full breadth of the algorithm of how the case mix is decided and the compounding factors and how that's weighted to determine the final class is not always going to be known, and that will be set from the Department of Health's body that looks after Anac and the NWOW. So there will be processes in place. However, if a facility believes that or would like a review of the class that a resident has been provided with, but they will need good reason to ask for that review. So they may have somebody that's classified through the branch of assisted mobility, but they believe that person is not mobile, or somebody classified as independent mobility, but they have reason and allied health assessments to determine that this person should be classified as assisted mobility, and there's mechanisms in place to request for that review of their Anac classification. So I'll just circle back to where I jumped to. So you'll start to see classes 1 to 13 spoken about. You'll start to see there's already quite a lot of focus on manual handling and mobility within residential aged care, and rightfully so, but there'll still be even more focus on that because there's such a large component of Anac on mobility, as well as a focus on cognition, because in that second piece of the case mix, it's quite a deciding factor. So that leads us to go, well, what makes up the Anac? What sort of outcome measures? Because that leads us to know what sort of outcome measures as allied health professionals and health professionals, registered nurses, etc., working with residential aged care, are we likely to start using a lot. So some of these that you'll see quite a lot moving forward is, in particular, we'll start to see the use of frailty scales a lot more within residential aged care, and up until this component we haven't seen them used a lot. The reason the frailty scale is included, in particular the Rockwood, it's very quick and very easy to administer. It's shown to be quite sensitive as compared to more complex frailty scales to use that use dynamometers and ulnar measurements and weight loss, etc. This is a very simple tool to administer, but it's still very sensitive. And the reason that it's in here as well is that there's good research to show that someone's frailty scale is quite linked to their where they are up to at their stage of life and how much longer they are likely to live. And that can very much to determine some of that component of their case mix. We'll see pressure areas being more focused on, and we know that there's a heavy focus already, but the Braden scale being the primary one used. The DEMI, which many have used maybe in the past as a mobility tool or a mobility assessment tool, there's a modified version of the DEMI used in the Anac, and it's likely that you see these measures start to form part of the care documentation used within residential aged care facilities. Some of these outcome measures will start to be used within the care management practice systems as well. The DEMI, the modified component of that is primarily the jump. If you know the DEMI, it has a jump component in it, which is not suitable for most of our older adults living within residential aged care, as well as a pick up a pen off the floor, which primarily is not suitable from a risk management point of view for an external workforce, as well as most likely they've made a decision there through RUCs of the infection control and standardization of what type of pen, etc. The Australian Functional Measure is sort of a modified version of the FIM if you're used to it, so something similar to that. And then the Behaviour Resource Utilisation Assessment, or shortened as the BRUA. So obviously you could do a whole presentation on most of these outcome measures, how to administer them, how to score them, etc., etc. Just trying to provide an overview of these are some of the outcome measures that you'll start to see more moving forward in residential aged care, and that gives you an idea why, because they are within the Anac tool. The rest of the Anac is split up into different areas or different sections, and most of those look at technical nursing requirements, knowing that the cost of care of looking after somebody significantly rises with complex nursing requirements. So there are questions for the external assessor to answer around these items: the need for oxygen, enteral feeding, tracheostomy, catheter care, stoma care, etc., etc. So you're seeing that it's quite specific from the resource utilization and classification study that they've been able to link the components of care that we provide in residential aged care to what actually is the significant drivers of the cost, so that then they can assess for that and then administer the funding as best as they can. So classifications, like I said before, no more high, high, high. If you've got a deep knowledge of the aged care funding instrument, you would know what I'm referring to with HHH or LMH, etc., etc. Touched on this classification tree just before, and you'll start to see that printed out in aged care facilities and referred to a lot more moving forward. Hopefully over time we see more information and transparency about how the compacting factors are impacting the classification, especially through these middle branches. However, that is not fully known at this stage. Around business rules, so this happened with RCS transitioning to ACFI and is now happening again with ACFI transitioning to Anac. There needs to be rules in place of how that transition happens in a smooth manner. So there's lots of different rules in place, and there's certainly not a breadth of time to speak to them all at this presentation tonight. It's important to know that beyond what I've written here, and I'll discuss in a moment, is that facilities, there's a fund for the Department of Health to administer to guarantee facilities their funding level, to prevent somebody that's classified at a certain level from possibly dropping and the facility losing funding. So there's been quite a lot of correspondence in the Department of Health emails that go out to the residential aged care sector, talking the sector through that and what channels that they need to go through. There's also rules in place, as there was with ACFI, around things with hospitalisation, etc. So reading through this, because Anac can be quite complex, and it's always important to refer to your notes, as I am doing right now. Providers can request a new assessment for care funding if a resident's condition has changed significantly, and that includes hospitalisation for more than 5 days, or 2 or more days if they had had general anaesthetic. So they will be really important pieces for a residential aged care facility, and who is looking after these components of flagging Mrs. Smith has went to hospital, what's that workflow within the residential aged care facility of determining has this occurred and should we be asking for a new Anac external assessment. So it's not mandatory to request that. So there needs to be a good working knowledge at a residential aged care facility of Anac and those components of mobility changing, but also some of the business rules to know, should I ask for an appropriate reassessment here because the care needs have changed. So providers may also request a reassessment where they consider they have changed significantly, irrespective of a hospital admission. So the mobility has to have changed, as you'll see down here. So a significant change means they have moved a mobility branch and more than 12 months has elapsed since the last assessment for classes 2 to 8, and more than 6 months has elapsed since the last Anac assessment for classes 9 to 12. So this is a good example, once again, of seeing that a higher class mix, and for an old adult meeting, this is someone much more frail, maybe more along a palliative pathway, is likely to have their care needs change a lot quicker. So quite complex, and I know many may be listening going, well, this is quite a lot. It all felt quite a lot at the start of ACFI, and over time it starts to become quite normal. The important part of Anac is it is externally assessed, so that weight of the knowledge on the residential aged care facility and the allied health team having a very robust knowledge of all of this won't be as extreme. However, there will still be quite a few team members at each residential aged care facility and in organisations that will need to have quite deep Anac knowledge and design quite simple workflows for care teams. So across assistants in nursing, enrolled nurses, registered nurses, through to leisure and lifestyle, through to allied health teams, having a good working knowledge of Anac and where are those components that they need to flag. So some of these pieces, especially around hospitalisation, that's not a lot to know for an allied health professional, knowing that tonight we're speaking predominantly to the changes in allied health. Speaking to the assessors, not everyone may know who an external assessor is and what type of experience they may need to have to be conducting these assessments. So the assessors need to have a 5 years of minimum experience as a registered nurse, a physiotherapist, or an occupational therapist, and they need that experience within clinical settings for aged care, noting that that can be geriatric evaluation, rehabilitation, palliative care, and community nursing, including people living with dementia. So they have to have relevant clinical experience across the residential aged care setting. And an example of that is one of our experienced physiotherapists unfortunately moved to Sydney, and we don't provide services in Sydney. And she became an Anac assessor. So she had possibly 15 to 20 years of aged care experience working across residential aged care and community aged care programs. So that's the type of person that would be stepping into facilities, completing these external assessors. So quite a high level of clinical experience. One of the things that I mentioned previously was that there is an independent body, well, as independent as you can be from department, noting that you're a part of it, that will be reviewing the NWOW, and that's the Independent Hospital and Aged Care Pricing Authority. So they will be reporting that pricing advice to the Department of Health to look at how they modify that pricing each year to impact the funding that's distributed to residential aged care facilities, not just for the care component of Anac, but also that base tariff that's tied to the predominantly the metropolitan, regional, rural, and very remote modified Monash zones. So previously that was the Independent Hospital Pricing Authority, and it's been expanded to take aged care into its portfolio. So reform timing, noting that there's a lot going on in aged care reform, and the purpose of this presentation was speak to a lot of aged care reform, but Anac makes up a big piece of that and is very timely because it's only a bit over a week away. But there's a lot else, there's a lot of other things that are going on within aged care reform as well. And a lot of that has been progressing off the back of the Aged Care Royal Commission. So some things have already been occurring. So if you look to the left here at number 1, sort of speaking to some of the Anac thing that we've spoken about, the shadow assessment period commencing, etc. We've had different changes on reportable items from aged care facilities, reporting on income, expenses, care staffing minutes has been quite a popular thing in the media, and rightfully so. Food and nutrition expenditure as well, also quite prevalent in the media, especially around this time of late 2021 into 2022. We had a change in how statements and the requirements of how statements are presented to residents. We've had October 2022 Anac replacing ACFI. We have star rating systems being published for residential aged care facilities coming. And then we have the progression to the mandated care minute standards for residential aged care facilities. And there's lots of different things also coming in amongst that. But I wanted to see, sort of just show on a continuum that there's this progression of more things coming into the residential aged care reform sort of pathway, all on the back of findings and recommendations from the Royal Commission. So I think sometimes when a large component like Anac comes in, it can feel like, oh, we're all done with reform. There's a lot of other things coming as we see this continuous improvement sort of roll through the residential aged care sector. So a bit of a summary, and I'll speak a little bit beyond the summary page to try and just give some extra value across allied health in particular, of what should you do and how does this impact you as an allied health professional. What sort of things, if you're a residential aged care facility, a facility manager, care manager, ACFI manager, what should you be thinking about with allied health? And if you're a general practitioner, practice nurse, what sort of things should you be thinking about when thinking about allied health care needs and who to refer to and what sort of services are available? So with residential aged care providers, you should be thinking about, and most have already been thinking about, moving clinical care models to involve objective measures that are included in the Anac. So things like the Braden should be your choice for pressure area. The modified DEMI should be your choice for mobility. So looking to have those things as a component of your clinical care or clinical governance models. Should be looking at that proactively, proactively training staff in these things as part of the transition. Easy to say those things when there's so many things going in with residential aged care as well in light of COVID-19. However, change management is about a slow as smooth approach. So trying to just chip away at one thing each week regarding this and the transitions is really important, and hopefully you've already started along that journey. Should be thinking about engaging with consulting companies if you feel like you need an extra hand. So, and there's plenty of consulting companies in the residential aged care sector that can help you around change management, around financially modelling the impact of the transition, knowing that there's some support materials from the Department of Health that you're probably already accessing, and preparing systems for changes in these reportings on the timelines as well. Now, for providers around allied health, in particular the transition from ACFI to Anac, it's really important to have a clear change management plan for pain management. This needs to be handled in a consumer-directed manner. There needs to be choice, there needs to be control, shared decision-making. There needs to be assessing of pain. That needs to be documented via an objective assessment. There needs to be a change to care plans, and there should be a reassessment of any change as well. That could be also speaking to somebody that's a guardian or power of attorney to discuss those changes and why a change from pain management to a different type of allied health intervention program should be taking place, and how the effectiveness of that should be monitored and reviewed ongoing. If the pain management transition is handled poorly, it sets yourself up for accreditation standard issues in the future if these sorts of things are part of that audit, because it'll be quite clear whether choice and control and appropriate objective measures and consent has taken place. So it's really important to engage with your allied health provider that is looking after your pain management program at present, and have a very clear transition plan about how these things are going to occur, what sort of things are being said to residents and families, as well as across staff as well. For allied health providers, if you're providing pain management as a predominant component of your practice within residential aged care, you should have been looking at different models of care moving forward. So this can be looking at reablement and restorative individual and group programs, your normal assessment and care planning and manual handling components, and falls prevention and equipment reviews, and et cetera, et cetera. That should all be quite normal practice and normal hours there. However, there will be a change of what do those pain management hours, what are they moving forward? For us at Community Therapy, we're modeling quite a lot of our practice off some groundbreaking research called the Sunbeam Trial that many of you may have heard of. And that was predominantly focused on the care need of falls prevention and looks at group programs, challenging balance, challenging strength. And speaking to falls prevention, that study showed approximately a 55% decrease in the rate of falls within residential aged care facilities in Australia, which is, I think, wonderful research that we all intuitively know that we can do those things as allied health professionals, in particular, physiotherapy, occupational therapy, exercise physiology, allied health assistants. But we also know that there's plenty of other allied health professionals that can assist. And the beauty of Anac is that it provides no barrier there for the engagement of allied health professionals that can meet the care needs of a resident or a facility as a collective. That could be dietitians with much more comprehensive and regular menu reviews and individual reviews of residents around their weight loss and weight management. And that could be a more regular engagement with speech pathology as well. So I feel across our regions of the Central Coast and Hunter, New England, we engage with allied health quite well across residential aged care, but it's nice to not have that barrier there. So this slide doesn't necessarily mention GPs and practice nurses, but if you're listening to this either live right now or on the recording after, it's important to know that predominantly for physiotherapy and occupational therapy on site, if a facility has had quite robust pain management program running at the moment, they might have had an allied health professional on site every day. And so the access to timely allied health Monday to Friday was quite good. We may see some facilities actually decreasing their hours of the pain management program, transitioning across to a reablement and restorative care program, where there may be some business days a week now that there's not an on-site allied health professional. So that's worthy to note if you're looking for a post-hospital discharge and a change in mobility. There may be some changes to the clinical governance and who is assessing there, as well as what sort of normal services are accessible for the facility. So my recommendation for GPs or practice nurses would be just to ask the facility or facilities that you're engaging with and that you're providing support to the older adults living at those facilities, what changes to allied health services are happening as part of Anac. So it's a very easy action item that can be the next time you're on site, or if you're predominantly operating via telehealth at the moment, just sending an email to your point of contact. Hi, I'm just wondering, with Anac, is there any changes to access to allied health that I need to be aware of? It's a really good action point to have. And then across facilities and allied health providers, it's almost the same action item. I like to have really simple action items for people to consider, because as you can see, this can be quite a complex topic. You should speak to each other and say, hey, what are we doing around Anac to start the ball rolling? I would assume the ball is already rolling and has been rolling for some time, but if it hasn't, those conversations need to be had of where only, we're less than 2 weeks away at the time of recording to Anac. What is our transition plan? And I can speak maybe a little bit. I presented to the Australian Physio Association and a couple of 100 physios live on a similar presentation, but a little bit more physio specific. Some of the action points there I had was also to just acknowledge your fair work entitlements. If you are employed as an allied health professional and your hours are decreasing, it's important to know that you have fair work entitlements there around notice and around redundancy. And if you're an employer, you also have those responsibilities as well. So just having transparent, slow as smooth change management practices is really important. I think during COVID, we've all had lots of things happening, and it can feel that things in our workplaces are moving quite quickly. Keep it simple and just speak to each other about the plan. Transparency is the best practice moving forward. So hopefully this has provided some action items and some things for you to consider. You're welcome to ask some questions now, and also welcome to contact me after if you don't feel confident voicing your questions in this forum as well. So thank you so much for your time.
Thank you very much, Scott. That was excellent. And we do have some questions. All right. So this is a question from Suja. Thank you very much for sending your questions through. What will be the role of AHP in Anac model going forward? Will AHP still be doing initial assessments with new residents while they are awaiting external assessors?
Yeah, it's a really good question. So yes, what we're doing there as an allied health professional working, that question is primarily speaking to an allied health professional working on site, being that main allied health professional on sites, typically a physio or an occupational therapist at most facilities around Australia, is yes, they would be doing the initial assessments, they would be doing a physio or occupational therapy comprehensive assessment for that person's care needs. What's their mobility? Do they have pain? Do they have pressure area needs? Do they have complex equipment needs? What sort of bed? What sort of mattress? Just usual residential aged care practice, manual handling requirements, etc. Sometimes that will be allied health referrals if you've identified another care need, etc. So those sorts of things, and hours allocated to that practice between an allied health provider and the residential aged facility should be unchanged with Anac.
Thank you for that. There is another question from Rex, which I'll ask, but in the meantime, can I just, if you do want to put questions through, you'll find the question tab in the little panel on the side, just in case you're not able to find that to send your questions through, but please, we've got time, so send those questions through to us. So Rex is asking, he's saying, hi Scott, has anything changed for DVA clients? Will it be easy to sort out who is considered high or low care under the new Anac?
Yeah, it's a really good question. At present, not so much the supporting material around DVA even within DVA sometimes seems to lag a little bit. So I haven't seen the full commentary of how that interacts with where the both the equipment needs, but also the access to allied health and how that impacts with, you know, D904 referrals, etc. How that changed versus how it's been operating so far. So I would expect that we see increased commentary around those things at the moment. And the point of action on the crossover of what do you do in the first weeks of October with those considerations would be calling through to DVA for those residents to ask what changes, if any, need to be considered.
Thank you. Emily is asking, what does an external assessment look like or involve? How long does it take to complete?
Yeah, another great question. It's important to note that the external assessment does not always need to involve that sort of face-to-face component of the whole component of Anac. So a full external assessment may only take 20 to 30 minutes in full. That can involve observing the resident, that can involve actually going through a full assessment with them, or some of that may be just reviewing the notes and the care plans and the assessment that the facility has completed. So somewhat similar to how an ACFI validation was occurring thus far. Often it was reviewing the assessments, the care plans, the progress notes to look for anomalies, but also then looking at that in person. And an example would be, let's say that the facility assessment says that somebody is not mobile, and that's where the external assessor starts their assessment. Great, I just need my mobility classification here, not mobile. Okay, they then move on to another part of that person's care plan and see mentioned that they're one assist. And then they see in the progress notes that Mrs. Smith is actually ambulant independent with her walker. That would prompt them to spend more time on that assessment and go do a full assessment by themselves. Where it can also vary is some facilities may have already been doing a modified DEMI, so they can start with that. Others may not do it at all, and they will have to do that in full. So 20 to 30 minutes, but it could take 40 to 60 minutes if there's some complexity to the assessment.
Thank you. Kevin is asking, what would these changes mean for limited rego physiotherapists? Great
question. That's a really good question. These are great. In terms of limited registration, no change. So why it's a really good question is that there was a component of time under ACFI where the Department of Health gave some very short notice that they were going to restrict the delivery of allied health services under the pain management component of ACFI only to fully registered AHPRA allied health professionals, and there was very limited sector engagement about that. That was overturned very quickly by the department, and they went back on that consideration. So there's been no changes in terms of a limited registration allied health professional being able to provide those services, and there should be no change moving forward because there's no component of the Anac tied to what is actually provided by the allied health professional on site versus what the facility was doing with of ACFI. They needed that component and that evidence to be able to claim that component of a 12.3 or 4A or 4B for the ACFI, so no change.
Okay, Amelia's question is, thank you, Scott. You mentioned many different types of assessments, but I didn't notice any nutrition screening tools mentioned. Is this something that may come in as a standardized recommendation tool in the new assessment models? Dietitian question.
Yeah, really good question around dietetics. So it's important to know that Anac is an external assessment to try and determine what's driving the cost of care. So in terms of how is nutrition and dietary components funded, that would predominantly be through the base tariff of like that's a usual care need for the facility. So you're unlikely to see a change to the structure of Anac over it's in the entirety of its lifespan. Unlikely, but I will note that it has more flexibility to be changed over time. So there could be a component of it changing, predominantly maybe by the pricing authority. Where I think we should think about nutrition and dietetics and the care standards being lifted is around some of the mandatory reporting items that are already in fact for residential aged care, which will be prompting facilities to engage more with regular dietetic reviews, not just across individual care needs, but across the whole facility of making sure there's analysis of menu reviews. And I know that Dietitians Australia has a very good assessment tool for dietitians to use for that. And one of our dietitians today was having one of those reports reviewed by an allied health manager. So it's weird that you've just brought that up, that there's some really good support there from Dietitians Australia on like a template that dietitians can use. So yeah, in short, unlikely to see a big change to Anac over the 10 years ahead. It's been very well looked at of how it is driving or representing the cost of care, but I think you should feel very confident that there'll be an increasing engagement with dietetics from aged care facilities because they have mandatory reporting components now around dietary care needs and weight loss, etc.
Thank you for that. Lucy has a question with a couple of questions. How will the physiotherapy treatment be planned for each resident? How often will treatments occur and how many times is allocated? Is goal-setting treatment planning done as part of the initial physio assessment?
Yep, really good questions. So where a lot of these can come from is that the change in practice within pain management very much was quite dictated by the way the tool was written. The 12.4a, 20 minutes of that therapy per week. A 12.4b started as 4 times, became 4 days, and then became 80 minutes over 4 days. So it was very prescriptive of how that therapy was provided. So the good thing about Anac, but also the challenge for business models and an allied health professional and a facility determining that together is they can design that how they feel best meets the care needs of the facility and the resident and implements the research. So maybe we can start with how would an assessment occur? How it occurs right now. An initial assessment should occur. We should be determining the care needs of the resident. We should be determining if we're speaking to a physiotherapy or occupational therapy, exercise physiology sort of therapy program. We should be looking at this facility, are we going to have just group programs? Are we going to have individual sessions as well? Where do we sit around the rehabilitation component of the care legislation, and what is the facility's responsibility and what is the responsibility outside of the facility for rehabilitation, because sometimes that can vary. Is leisure and lifestyle engaged in these group programs? Is an allied health assistant engaged in these group programs? So it's really redesigning the whole program. So to put that in, I guess, some practicality, what are we doing at our residential aged care facilities? We're reassessing everybody and we're then actively looking to build group and individual programs, modeled predominantly off the Sunbeam Trial, but noting that it predominantly is looking at falls prevention, strength and balance, and there's other aspects of therapy that we can be looking at as well. So it's a full redesign of a business model and a clinical governance model. And then speaking to, I guess, another part of the question is like, how often should you review? typically that's an easy decision to make of reviewing at the minimum, that is the care plan reviews for the facility. So just align with that frequency, which is typically going to be 3 or 4 monthly, but then have some sort of, whether it's on the care documentation that the registered nurse or care manager knows how to refer back to you because the care needs have changed. Like, I know Mrs. Smith is not due for their next review for 3 months. However, they had a fall and they need to be reviewed. Those sort of practices don't change. That all of that's either through the practice management software, through an email, or it may just be an allied health folder, paper-based, that's on your desk, and the care manager knows to write, Mrs. Smith had a fall, please review them. And that's why when I spoke to previously of the assessment and care planning hours should be unchanged, because there's no change in the requirements there under the facility. The change is more that we get to be much more creative now of implementing the evidence base for therapy programs, both group and individual, and that's challenging because you have to create a new business model.
Okay, thanks, Scott. Michael is asking, how do you see exercise physiology utilization changing with Anac?
I think there is an increase in the utilization, and that is in several ways. I think speaking across to COVID impacted migration or immigration, which then impacted the amount of allied health professionals under either limited registration or visa pathways. So the amount of allied health professionals available decreased, and we saw that across all sectors, not just health. So we saw, lots of job shortages, so where that then flows through to exercise physiology is in 2 ways. One, the pain management dependency of ACFI really limited any engagement or a vast engagement with exercise physiology because of the dependence on manual therapy as pain management. Taking that away now, there's no restriction of engaging with exercise physiology to be able to meet those care needs of certain aspects of therapy programs. And that's exactly some of the components that we're doing at community therapy. So where for the individual and therapy programs, you now are able to meet those care needs with a variety of different allied health professionals, whether that's physio, OT, EP, allied health assistant, noting that the Department of Health and NDIA, the agency, have been very clear that they want to see a therapy assistant workforce growing. An important part of that is just knowing what's that sort of clinical governance on sites and within organisations to be supporting possibly newer health professionals in a setting that they're not used to, and knowing that you're going to have a skilled health professional and exercise physiologist within that setting that they're maybe not as used to working in as much. And I love it when we get a skilled health professional working with an older adult because they're able to identify other care needs. So if that exercise physiologist is running a group exercise program, do they know who to refer to at the facility if they saw Mrs. Smith having trouble swallowing water? Is there a speech pathologist referral? So I think just having some consideration around what sort of training, upskilling is needed for different health professionals entering, but also recognizing that it's well within the scope of practice to make those referrals, and it's not a lot to skill up on for a skilled professional.
Thank you, Scott. We've only got 1 minute, but I will ask Jordan's question as our last question. Given Royal Commissioning findings note aged care is understaffed and undertrained sector, do you think Anac adds complexity and strain, or is it just different, and once adjustments are made, it will assist with a more efficient funding model?
Yeah, really good question again. So I think one of the easiest way to think about some positivity on that question is that the administration of ACFI by the facility took a lot of time from not just the registered nurses and the enrolled or enrolled endorsed nurses, but in particular the assistants in nursing. So that was completing different charts and lots of documentation that was, so lots of time shifted from providing support or providing training to just doing paperwork. There should be a very big opportunity for facilities and organizations to simplify their workflows and the amount of documentation that's required to facilitate care standards rather than to tick boxes for ACFI validation. So I'm optimistic that there's an opportunity for facilities to take that and run with it, but they're also somewhat dependent on the care documentation that they're using. So lots of that documentation software and the assessments and the tick boxes within that were built over time to make ACFI validation easier to meet. That needs to be recoded. So I think it will take time to see the efficiencies. How long? Maybe 12 to 24 months. But I think from at least an allied health perspective, those changes of being able to engage with evidence-based more easily will be happening from next month.
Awesome, thank you. And Lucy shares your enthusiasm. She says, that all sounds like a much more appropriate and effective use of allied health within RICF. Very exciting times.
Yeah, definitely. Oh, that's lovely.
Well, thank you very much, everybody. We're at the end of our session. Thank you so much, Scott, for an excellent presentation and for answering all of those questions. That was awesome. As I mentioned, an evaluation will come out to you automatically, and it will also have the link where you can find the link to the education library for the PHN, where this recording and the slides will be made available to you. So thank you very much for joining us tonight, and please enjoy your evening, everybody.
Thanks so much.
Thanks very much.